Welcome to Derm-It Trotter, Don't Swear About Skincare, where host Dr. Shannon C. Trotter, a board-certified dermatologist, sits down with fellow dermatologists and skincare experts to separate fact from fiction and simplify skincare. Let's get started.
Welcome again to the Derm-It Trotter, Don't Swear About Skincare podcast. Today I have a special guest who's near and dear to my heart, my previous program director for dermatology residency, Dr. Scott Drew. He's a board-certified dermatologist and expert in the diagnosis and management of psoriasis with over 30 years of clinical and research experience. He has lectured nationally and internationally on topics in dermatology, has had many peer-reviewed publications. He's received numerous awards from local, state, and national organizations for his work in dermatology and philanthropy in Africa, Asia, and South America. So welcome to the podcast, Dr. Drew. It's exciting to have you here today.
Well, hi, Dr. Trotter. It's great to be here. One of my favorite resident and one of the best. So thank you for having me.
Well, thank you. It's so great to have you back with us, from a standpoint of now on the podcast versus, teaching me all about psoriasis when I was in residency. And I think, the hardest thing, with psoriasis is that people just don't really understand, what is it? They might think they have eczema, but you're like, no, you really have psoriasis. So when you have a patient that comes in, they're like, okay, I have psoriasis. What does that mean? How do you explain that to them?
Well, the first thing I like to tell a patient, I actually like to physically touch them to let them know that I'm not afraid of catching it. They don't have some contagious disease. They don't have cooties, that they're a human being with wants and needs and emotions, and that we're going to do our best to make them better. I like to let them know that it's not just a rash, but it is a systemic problem. People have other comorbidities, other issues that are related to the psoriasis, whether it's joints or whether it's excessive weight and extension or withdrawal issues, whether it's malaise or depression, and that it's not just a rash, and that it's important to treat it because not only does the skin bother people, but once you start to get other problems like joint pain, and that sometimes can be harder to reverse. So it's important to explain to people it's not something that you did or something that you ate or some activity, but it is a real live thing that's driven by your own DNA. And I think people a lot of times think that there's something they've done. It's their fault. And we want to get rid of the stigma. We want to get rid of the blame. We want to get rid of the shame, and make people know that they can have psoriasis, but not be psoriasis.
Yeah, I think that's really important because you're right. They used to, call it, I remember you telling me the heartbreak of psoriasis, and the famous people, including authors that have suffered with it. And I think it is complex for patients to get because, it really focuses on the immune system, their own immune system. They feel sort of betrayed by, and their skin is kind of feeling this process where, essentially they're making skin too fast, and that results in inflammation and the redness they see and the burn and the itch. And so when you talk with a patient, when they come in, they're like, hey, how do I know if I have psoriasis? What do you tell them to look for on their skin?
So almost always people know something's wrong because they've all been to the grocery store or their kids have not been invited to some function because the community that doesn't know a lot about skin disease can extrude a sense of, oh, that's contagious, or what's my kid going to get that? So, what I like to help people understand is where this rash is located on their body, how it is either already extended or can extend, how it can be on all kind of places. Because, psoriasis can not just be on the elbows and knees, it can be almost anywhere. And people can sometimes be very, very embarrassed to even talk about it. Oh, I've got it on my scalp, and, people think it's dandruff. I don't wash my hair enough. Or it can be the palms and soles, and people are inhibited by shaking hands or going on job interviews or dating. It can be in the soles of the feet, and that limits athletic activity. It can be in the pelvis and the groin, which can impact body function and sexual awareness. And all of that contributes to this giant sense of self. And people can actually have significant mental health issues related to this. So I think it's one of the joys of being a dermatologist is actually being able to not just take care of this rash, but take care of this systemic condition, systemic disease, and really bring people's quality of life back to where it should be. Every kid should be able to play sports. Every person should be able to go get a job. Everybody should be able to go to the gym or exercise or walk the dog without the joint pain. And it's really, I think it's a privilege for us to be able to walk people through this and help them explain what caused the disease, what options we have to take care of it, and what they can look forward to. Because, when Shannon, when you and I first met, sadly, many decades ago, there weren't as many options for treatment.
Right.
And now some of the new standards by our organization, the American Academy of Dermatology, and advocacy groups like the National Psoriasis Foundation, tell us and tell our patients that people can expect to be 99% better 99% of the time. And that is a Herculean event that we never thought we'd see in our lifetimes. So we can actually say to people, I'm going to help you get better. And you don't need to feel ashamed about it. And you can be empowered about it. And you don't need to worry about having a lifetime of these big, thick, silvery, painful, itchy plaques that also give you joint pain.
So, I think what we're talking about here, we look at psoriasis, you just talked about, the scaly red plaques, they can itch, they can burn, all the locations that can affect somebody. And I think it's really important we honed in on, two things. One, that impact on quality of life. You're right. Can patients function normally with psoriasis? And in today's, day, we can offer, successful treatments for patients to get them there. But the other thing you mentioned that I wanted to dive in a little bit more is that how, psoriasis really is, to use a cliche, more than skin deep. Mentioned, it's that systemic inflammation. You touched a little bit on kind of the arthritis that we see in psoriasis. I think a lot of people think, I've got sore joints or I got stiff joints. Do I have psoriatic arthritis? So can you talk a little bit about how psoriatic arthritis might be different than maybe your classic just Uncle Arthur, if you get that classic arthritis, and, how do we diagnose it and how do we, kind of treat that as well?
That's really very, very important, Dr. Campbell. Many people don't even understand the correlation between the genetic problem that causes the skin disease is linked and is the same that attacks the joint lining. And I would say every week, or maybe even several times a week, a patient will say to me, no, I don't have joint pain. I don't have psoriatic arthritis. And then they'll start therapy and they'll call back and they'll say, you know what? I started taking my medicine and my joints feel better than they have in years. I must have psoriatic arthritis. Because unfortunately, there's no blood test that says, yes, you have psoriatic arthritis. So there are certain clinical historical signs and some clinical signs that we look for. Psoriatic arthritis tends to be symmetric, not always. It can be in the fingers, it can be in the spine, it can be in the extremities. And there are certain characteristics of the quality of the pain associated with some deformities of the joints and some swelling of tendons and ligaments that are really suggestive of psoriatic arthritis rather than the arthritis we see of old age arthritis or overuse arthritis or even rheumatoid arthritis. The good news is, because we have effective treatments, most dermatologists now are very, very adept in diagnosing psoriatic arthritis, either solo or in concert with our colleagues in rheumatology. And most importantly, I want to stress to people that psoriatic arthritis is manageable. It's better to manage it early because once the joint space is gone, it's very hard to get back. And this is why in our offices, we have patient information and web references and posters, and all of my staff is adept at counseling people as well about how to detect, how to prevent, and how to treat this. Because, let's face it, once your joints start to hurt, it's not fun to go for a walk or to go to the gym. Once you're on treatment and that starts to get better, it's very, very motivating for people. The other thing about arthritis is psoriasis on the skin and the joints can, as I said before, lead to some depression and mental health issues. And if you're depressed, the last thing you want to go and do is go to the gym. And so you're sitting at home and watching TV, and maybe instead of exercising, you're having an extra candy bar or some chips. Then you gain more weight, and then you get much worse arthritis. And it creates this cycle of psoriasis and depression and increased body mass. And those are all things that add to patients' frustration, because for a while, we weren't able to offer patients successful strategies to get them significantly clearer. So I think sometimes patients feel disenfranchised, and why go to the doctor and get yelled at again and told you're wasting your time? And now we can tell people, we can help you get better. We have to give them hope.
Yeah, and I think we've got opportunities, like you said, to do that now. And talking about, the depression sort of association, where we definitely see an increase, risk for that in our psoriasis type patients, that they're struggling with other things. What do you counsel your psoriasis patients about other, you mentioned the comorbidities or other conditions that they could be at risk for? Are there things that you talk with them about that they need to sort of be monitored for, by their primary care physician? Because we often see these things in psoriasis.
I think it's very important. And again, that goes back to the idea that psoriasis is not just a skin disease, skin, joint, and it's a systemic disease. And it has other what we call comorbidities. One of the most prominently well-known is this idea of the metabolic syndrome. So people that have psoriasis are at increased risk for cardiac events. They're at increased risk for hypertension, for heart attack, for stroke. They have increased risk of diabetes. They have increased risk of occupational falls and injuries that are often associated with the joint disease state. So it's important to partner with not only your dermatologist and rheumatologist, but with your primary care doctor to address all of these issues. And we can't underestimate the importance of the mental health component of that. And now, quite candidly, in my experience, in my sadly decades of experience, I find that mental health issues improve with treatment of psoriasis. When people get out of the shower and they have a mirror and they look at their wet, naked body and they see these big plaques everywhere, they get depressed. And when these plaques go away, it gives them life again. I mean, I have patients who skip their 25th anniversary cruise because they don't want to be seen in a bathing suit. Women don't go get mani-pedis because they're embarrassed of the nail disease of their psoriasis. Older men who are told, oh, you have diabetes and go get some exercise, won't go outside walking in shorts because they're embarrassed by their knees and their elbows. So once the psoriasis goes away, it makes their mental health better. And I think it's important to avoid the stigma, to go online or go to your support groups or go to your patient advocacy groups and talk to other people who have psoriasis, because a lot of people, up to 3% of a population has psoriasis. So you go to your workplace and look around, someone else has got it. And it may not be as bad as yours, or it may be worse than yours, but it is not you're the only person on the planet to have it. This is a disease that has a shared commonality among our communities. And the more we talk and share about it, the more the stigma goes away. And there's no reason to have shame. No one's ashamed that they have a broken arm. Nobody's ashamed that they have hypertension. There's no reason to be ashamed that you have psoriasis.
Yeah, I think that's important, and it gets underscored with a lot of skin disease, but especially in those psoriasis patients. And, we've touched upon, that this is a new day and age, for treatment. Can you talk a little bit sort of about the spectrum of treatment, starting at the very basics, maybe from topicals all the way to where we are today? For a patient out there that's listening to us now and thinking, I've got psoriasis, but I've had it 20 years. There's not really much I can do about it. Can you really talk about, what's that spectrum and how can we really change their life?
I've had a lot of people say to me, oh, you're the 12th doctor I've seen. I haven't seen anybody in years. But really, Dr. Campbell, there has been such an advance in psoriasis in the past year, the past 3 years, the past 7 years. There are new drugs coming out for psoriasis literally every 6 months. And the improvement in therapies and the safety profile is exponential. It's huge. It's epic. And so if you have just a little bit of psoriasis, there are some new therapies that are topical that are not steroids. They're not the kind of drugs that suppress your immune system, which is what steroids do. These are drugs that directly impact the specific molecule that your DNA makes you make that triggers psoriasis. And these new medications target that. So you don't have to worry about those crazy side effects that we have from steroids. And so if you just have a little bit of disease, those new topical agents are very, very, very effective. Now, let me say there's also psoriasis that can be severe, but focal. I mean, you may have just a little bit of psoriasis, but in a very bad place. Say it's just your face or just your hands and fingernails or just your pelvis. And that may require more aggressive therapy, but aggressive doesn't necessarily mean less safe, because our newer aggressive therapies, whether they're a pill or an injection, are very, very safe and effective. And I also want to make people aware that sometimes who can be afraid of medicine, we should never discount a medicine unless we consider what is a side effect of doing nothing. If we do nothing, we know the psoriasis is going to get worse. This is not a static disease. This progresses. The skin lesions, the joint disease, the mental health. So when you read about a drug, I also encourage people to read about what psoriasis does. So to your question more directly, there are several pills, oral agents that are extremely effective for patients on an everyday basis. That, again, is not prednisone, is not cyclosporin. These are drugs that are very, again, targeted. They do not suppress your immune system. They affect the molecule that in your body that your DNA targets you to make and inhibits psoriasis from happening. Other drugs make the psoriasis go away once you've got the disease. These new drugs make the disease go away, but also help you not make new psoriatic plaques. They're revolutionary. They did not exist when I was in medical school. For people that have more severe disease, we have a class of drugs called biologics, and they're injectable drugs, and they're sometimes given every 2 weeks, every 4 weeks, every 2 months, every 3 months. And there was a new drug that just came out a few months ago that's every 3 months. Once a quarter, you take a shot, and you can do that at home. And it's kind of like an EpiPen. It's not like a big needle you got to draw up. It's a push the button and it's easy, and it takes care of the skin and the joints and many of the other comorbidities that are associated with psoriasis. These drugs are very safe, very effective, and I just can't emphasize enough that these drugs give people hope and they give people their life back.
What do you say to some of the patients, with those medications? I feel like often, I have a patient come in like, yeah, I've heard this might help me, but I'm kind of afraid to take it because I'm worried about the side effects. Or I heard, if I take that, my immune system's going to be shot and I'm going to get sick all the time. How do you address those fears? Or maybe they're afraid of needles for the ones that are injected. How do you walk a patient through that to try to explain to them, more realistically, the potential side effects and potentially also how to get over that injection piece? Because needle phobia, I know it's a real thing for people.
Yep, absolutely. So I think the most important thing is to find a dermatologist that you like and you trust. And we have like a psoriasis center where I practice, and the staff and the other providers with me are accustomed to this. And we look people right in the eye and say, we're going to work this journey with you, because it's not a cookbook. Every psoriasis patient is different, has different needs, different expectations, different goals. My goal is to tell people, whatever your goals are, we can help you get there. So I think it's important to remind people what causes psoriasis. And let's face it, these molecules, these proteins that your body makes is a sign that the immune system is already abnormal. And these medicines aren't suppressing your immune system. They are normalizing an already messed up immune system. Sometimes the immune system is hyperactive. Sometimes it's producing too much of these proteins. These proteins are called interleukins or TNF alphas or IL-23. They're called cytokines, and your body has too many of them. So sometimes humorously I say, "Oh my gosh, your immune system's already messed up. We're gonna fix it. We're gonna help you fix it and get it back to normal." So I want to stress to people that these newer agents are not immunosuppressive. They aren't going to give you crazy immune suppressive disease. They're not going to increase your risk for tuberculosis. They're not going to increase your risk for HIV. They're not going to increase your risk for lymphoma. These drugs are going to give patients the chance of beating back your psoriasis. Again, redefining people as patients who suffer from psoriasis, not psoriatics. Who are you? You're a psoriasis patient. No. You're a patient that has psoriasis. Now, the patients who are needle phobic, that's real. I get that. I don't want to have, if I get a sore elbow, I don't want a needle put in it. I mean, who wants a needle? However, we have oral therapies, and some of them are brand new There are oral agents which are crazy effective, and they work on the extra proteins in your body called PDE4, and they also work very, very effectively without suppressing your immune system. And I want to also stress, Dr. Campbell, that if we have this conversation, you and I, again, a year from now, there'll be other agents, very likely medicines like JAK inhibitors, and oral interleukins that are available to patients to expand the options for people who are needle phobic. And again, there's no shame. There's no more shame in being needle phobic than there is in having psoriasis. You don't like needles. I don't want to take a pill. I don't want to take UV light. There are options for everyone. And I also want to remind people that you don't have to be 35 to get psoriasis. You can get psoriasis when you're 6. You can get psoriasis when you're 96. And don't let anybody tell you that you're too old, you're too young, it's not that bad, don't worry about it. If it bothers you, it bothers me. And in 2024, no one has to suffer the stigma of psoriasis in silence. You can, I encourage people to be empowered, to read, to partner with other people, to partner with a dermatologist who cares about you and your psoriasis, because this is not your granular psoriasis. This is a new day and a new age for psoriasis.
Even with the new age that we're kind of entering, obviously with the new therapies that are available that really target the immune system, what do you think about the role? You mentioned it briefly, but we haven't talked about it. Some people might think of back in the day, phototherapy was the mainstay, treatment. Where do you feel like that treatment still fits today? Because I know there are patients that that's been recommended to them or they've actually had it done. How do you feel like it fits within sort of the treatment approach to psoriasis?
Well, Dr. Campbell, I'm sure as you probably recall, when you were in training with us, we had narrowband UVB and we had a therapy called PUVA at the time. PUVA is not something I would jump to quickly. Narrowband UVB, there's certainly a place for that, particularly for certain subsets of psoriasis like guttate psoriasis. There are options for that. The problem with phototherapy is it's a little bit cumbersome because people have to come to the office often, right? It's very time consuming. You got to come into your office 2-3 times a week. You have to undress, put oil on, get dressed again. So it's not the easiest therapy, but there's a niche of people who need it. And I would say many, many practitioners have sort of moved away from that because it requires dedicated space. It requires dedicated machinery. It's got some consumables and lights that last a certain amount of time. It's not wrong. It certainly is an effective option. Like everything, you have to worry about, or not worry, you have to consider risks and benefits. So I think there are some people who may have an excess risk of skin cancer with that. We use it, but it is nowhere near as common as we used to use it. And also, if you're in a rural area, it's very difficult to find.
Yeah, I feel like access has definitely changed over time. But yeah, I think a lot of people would argue the treatments you went and talked about previously, the biologic therapy, some of the oral medications we have, maybe long-term safety better and potentially efficacy too, compared to, I think, where light therapy used to take us.
Yes. And what I am so empowered by, psoriasis is never a good disease to have. But if you got to have psoriasis, having it in 2024 is the time to have it. Because, Dr. Campbell, literally, I tell people in the office, we're going to help you get better. I no longer say, well, we're going to try this or we're going to see. We have a metric. It's called PASI. It's kind of confusing, but it is a number associated with the degree of percentage that I expect you to get better. And in 2024, if a drug doesn't give me PASI 90, I'm not going to use it. I want you to be 90% better in 4 to 6 weeks. And I mean your face, your scalp, your nails won't be correct, but nail improvement, pelvic improvement, palms and soles, joint pain. I expect you to be 90% better, and 100% better is not unreasonable. So again, I just think so many people over the course of decades, because let's face it, people don't like you and me, run to the journals every week and read about psoriasis. People are busy living their lives, going to their kids' sporting events, playing mahjong. They're not worried. And if they've heard psoriasis is bad, they don't necessarily keep up. You and I do this on a, I mean, I read about psoriasis every day. It drives my engine. And so it's important that we let our people and our non-dermatologist colleagues, our primary care people, our OB-GYN people, our internal medicine people, our endocrinology people know that these options are safe and effective. And people's lives can be better with the effective treatment of psoriasis.
I think that is well said. And as we kind of wrap up, I think, we've done a great job sort of giving a broad overview of psoriasis, sort of a psoriasis 101 for our listeners out there, just to kind of scratch the surface, if you will, of kind of where we're headed with psoriasis on treatment as well. And then, where can people find you, Dr. Drew, if they're looking for you?
Oh, well, I practice in Marion, Ohio and Mansfield, Ohio. That's in the center of the state. And our practice is called Dermatology Associates of Mid-Ohio. We're on the web, and there's 3 of us up here practicing. We love psoriasis and skin cancer and eczema, and we really love people who come in and have gotten better pretty darn quickly with the management of this disease and the advancement of many diseases besides psoriasis, skin cancer, atopic dermatitis, hidradenitis. The research in dermatology that's existing now is coming at a pace that's so fast, it's almost hard to believe.
Well,
and Dr. Campbell, I tell you,
yeah.
I am so proud of all that you've done and you have accomplished in your youthful career. It is just so impressive, and our practice and my family is very, very proud of you.
Well, thank you. You always know how to embarrass me no matter where we go. But I appreciate the compliment. It means so much coming from you. And it was an honor, obviously, to train under you and to continue. It's kind of funny being the reverse. I was like, oh, I get to be in charge with Dr. Drew today. That's kind of funny. I get the roles are reversed. But thank you so much for your time today and kind of providing that broad overview for our listeners, again, on Psoriasis 101. You guys know where you can find Dr. Drew. Stay tuned because we just started this conversation. So we're going to have him back to dive into this more deeper and talk more about, sort of the other issues surrounding psoriasis with treatment and where we can go from here in future treatments as well. So stay tuned.
Bye-bye, Dr. Campbell, and goodbye, everybody. Good luck with the management of your psoriasis.
Thanks for listening to Derm-It Trotter. For more about skincare, visit dermittrotter.com. Don't forget to subscribe, leave a review, and share this podcast with anyone who needs a little skincare sanity. Until next time, stay skin smart.